Hello, I'm Dr. Adami from the University of Verona in Italy, and it's a great pleasure to present to you this topic, which is my research interest on glucocorticoid-induced osteoporosis, and I will try to get the point if there is a safe dose of glucocorticoids for bone. There is or there is not, and in which patient. We all know that the glucocorticoid use is widely diffused. Still in 2022, we have a lot of patients on glucocorticoids, and it's very difficult to taper the dose. We don't know how to taper, to which dose. We don't know what to do with our patient with a low dose of glucocorticoids. And as this in this study, we had approximately 20% of patients with rheumatoid arthritis that still are treated with glucocorticoids. This is our experience in glucocorticoid-induced osteoporosis from approximately 60,000 women across Italy. And as you can see, slightly less than 50% of patients with rheumatoid arthritis, which is a very common disease, are using glucocorticoids chronically. So still in 2022. So it's some kind of a problem. And what is known is that we are not doing better from 1990s to 2000 or 2005, and still right now in 2020, we do not have improved our use of glucocorticoids, but because these drugs work, so we still are using that. And what's the problem with glucocorticoids? Well, they are associated with bone loss. We know that if you use glucocorticoids, you will lose bone over the time. But more importantly, they alter the bone mineral density fracture threshold. So in other words, people with taking glucocorticoids with fracture at higher bone mineral density, even at osteopenic or normal bone mineral density. But please get this slide very right. So we know that people with glucocorticoid or steroid users with fracture had higher thresholds, so higher bone mineral density. But we also know that they will fracture a lot more when they have osteoporosis. So the two messages from these studies are: first, we should care a little bit less of bone mineral density in glucocorticoid users, but if they have low bone mineral density and glucocorticoid use, we probably should give them a stronger therapy. And we also know that the dose is associated with the risk. We don't know whether there's a safe dose or not. This is the aim of this talk. But we know that the higher the dose, the worse it is, especially above 5 milligrams or 7.5 milligrams per day. And we also know the longer the treatment, the worse is the problem. So heavy users as compared to short users are worse. And here we have some kind of indication for safe dose for bone and glucocorticoids. This study was from 2003 by one staff, and they found that even at very low doses of glucocorticoids, namely from 5 milligrams a day to zero, there's some kind of elevated risk of fractures from ranging from 10% to 20% higher risk of fracture, which is relevant. This is the first hint. And we had another older study, very well conducted, a longitudinal study up to 15 years of prednisone use by Dr. Sag, which is a very eminent expert in rheumatology and also very international expert in glucocorticoid-induced osteoporosis, showing that if you are not taking prednisone with rheumatoid arthritis patients, you probably have the best survival without any adverse event. So this is comprised also fracture, but also cardiovascular risk. which is another topic which has been widely discussed in the literature, especially right now, the JAK inhibitors. But we know that glucocorticoids can increase the risk of cardiovascular events. And indeed, we had myocardial infarction with glucocorticoids. So this is something relevant, but the most important, most serious adverse event that one can experience using glucocorticoids is fracture. Fractures at the top of the list and should be at the top of our mind when thinking about adverse events in glucocorticoids, at least severe adverse event or serious adverse event. But is it steroids or inflammation? So there's a confounding by indication. We treat patients with steroids because they are not doing really good. So we are treating RA because they have higher disease activity. So the problem here is to rule out which is the major confounder. Is this inflammation or is steroids? And we do have many evidence that RA, as an example, can lead to loss of bone independently from bone mineral density. And this is very, 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 very well described in the literature, and it might be mediated by DKK1, which is a very important molecule that inhibits bone apposition. That's why we have low bone turnover and glucocorticoid-induced osteoporosis, but also inhibits, increase the activity of osteoclasts. So that's why we have erosions, and that's why we have fracture in RA or multiple myeloma or in bone metastasis. This is our study. We conducted very a large sample analysis on postmenopausal women in Italy affected by various diseases. As you can see, rheumatoid arthritis independently from glucocorticoid intake, and this is very important, is associated with higher risk of fracture. So independently from bone mineral density, from all the variables that you can see here, rheumatoid arthritis is associated with a higher risk. We have seen a higher risk for chronic obstructive pulmonary diseases, might be for increased risk of falls, like neurological diseases, or for we don't know that actually if there's an effect of inhaled glucocorticoids, which might be relevant, or malabsorption in inflammatory bowel disease. Those are problems that should not be relevant in rheumatoid arthritis. So something else is going on in rheumatoid arthritis, and that's why we ask ourselves: is there a safe dose for glucocorticoids in 2022? We do have a lot of drugs that are very efficacious in tapering glucocorticoids. We have a lot of treatment strategies. We treat our patient earlier. We have recommendations that asking us for discontinuation. So if there truly is a safe dose in 2022, well, we need a randomized control trial because of the confounding by indications. So we treat patients more aggressively if they have a more severe disease. And they actually did that. The Gloria trial aimed exactly to this. They want to explain whether adding prednisone chronically for 2 years to patients with older than 65 years might benefit from chronic treatment of prednisone. So they randomized patients to either prednisone 5 milligram or placebo for 2 years, and the first result was that you might have an improvement in bone disease in disease activity, because that's 28, which is my personal opinion, not really clinically meaningful, because we have 0.4, 0.3, 0.2 reduction, and that's 28, which is somehow very small, just should not be considered as as very relevant or good Euler response, but we might say that was significant. So there's an improvement in disease activity, but at what cost? Well, the trade-off was a 24% increase in patients' adverse events. So no severe adverse event mostly, but one of the most important, in my opinion, result was that there was a 4% significant difference between placebo, the increased bone mineral density, again, the effect of reducing the inflammation, and a loss in -3% in bone mineral density in the prednisone group. So if you take this result together with the reduction in DAS28, it is very relevant. However, we have no data from this study on antiresorptives or anti-osteoporotic treatment whatsoever. So we don't know whether the patients were treated, because this was a pragmatic trial. So patients have been treated for 2 years for their disease. So we don't know whether these patients were treated with anti-osteoporotic treatments. And to highlight the importance of this small, might be seemingly small delta in the lumbar spine between placebo and prednisone, this is what corresponds to. So if you have a delta with an anti-osteoporotic treatment of approximately 2%, you will have a reduction in fracture risk by 28%, which is incredibly similar to what has been demonstrated before by Basta, study I presented to you. And if you increase the delta, so if you have a 4%, you probably have something in between 30% here and 60% of vertebral fracture risk reduction. So the problem is that we cannot see a fracture risk increase because of the small samples in most of the studies, most of our RCTs, but we can see bone mineral density variation over the time, which are relevant, which is dramatically relevant. Bone mineral density is the major risk factor for fractures, actually, and increasing or decreasing bone mineral density has been associated with an increased risk of fracture or a decreased respectively. So this is very relevant. So is there a safe dose again? Might be, but probably lower than 5 milligrams a day, and we have very strong evidence on that. We have strong evidence coming from randomized controlled trial now, which might have attenuated the confounding by indication, and so we don't know whether there's a safe dose below 5 milligrams, but at least at 5 milligrams we know that there's no safe dose. So what can be done? What can be done to prevent and treat GM? I will go very fast here. We have some data on bisphosphonates, obviously, but never forget that this placebo here was the calcium plus vitamin D. So we do have evidence that vitamin D is relevant, is important. The baseline fracture incidence, fracture rates before this trial was very, very high, and then those patients were treated either with calcium vitamin D or bisphosphonate plus calcium vitamin D. So we do have evidence about the fracture risk reduction with calcium and vitamin D. But what about calcium alone? Well, there has been some data showing that possibly if you take a very high dose of calcium, you might have a fracture risk, higher fracture risk, which is probably mediated by confounding by indication. The very important result of this study was that if you take below 500 milligrams per day, you have a very high risk of fracture. When you stay in between 1 grams per day, you will have the lowest, and probably here there's a confounding by indication. So very, very high doses of calcium are taken by patients with high risk, and calcium alone is not the treatment. So you might have encountered a confounding by indication. And then we have other drugs. We have denosumab. We have very strong data on this. We know that denosumab can increase bone mineral density better than bisphosphonates. There's also a study on alendronate. I've not time to present that, but we have this very well conducted, high quality study on against risedronate. So we have very strong data. And then we have teriparatide, which is probably the best treatment that we have nowadays for glucocorticoid-induced osteoporosis. It targets the bone formation, so we have very strong data on that, and we have strong data on bone mineral density, but also on TBS, trabecular bone score, which is a proxy for bone architecture. And the teriparatide TBS increased, while no other drugs ever will make TBS increase in glucocorticoid-induced osteoporosis. So antiresorptives cannot increase TBS, so microarchitecture cannot improve microarchitecture, but teriparatide can. And then we have some very interesting preclinical data. We know that the absence of sclerostin, which is a Wnt inhibitor, so an inhibitor of bone formation, but also a stimulator of bone resorption, can protect from glucocorticoid-induced osteoporosis. So there's a very strong rationale for romosozumab, the new anti-sclerostin inhibitor, to be tremendously effective in glucocorticoid-induced osteoporosis, especially in the initial phase of glucocorticoid-induced osteoporosis, in which we can see a very high increase in bone resorption and a decrease in bone formation. So if you have a drug that can both, increase bone formation and decrease bone resorption, you probably have, win the jackpot. So yeah, bingo. So probably Romo for glucocorticoid-induced osteoporosis prevention or treatment in the early phase might be very, very good drug. And we have some clinical, very preliminary data that is safe. It is safe in rheumatoid arthritis. There has been some speculation in the last 10 years about the possible safety of Romo in inflammatory disease. We have now some clinical evidence supporting the Romo safety and efficacy, actually. So Romo did not affect the disease activity and increase bone mineral density to greater extent than denosumab in these patients. So it might be a very, very good drug for that. And with that, I want to thank you. Thanks for the organizing committee for inviting me, very important, and give my support to all the Ukrainian people. Thank you.